So welcome everyone. My name is Michael Hayes and it's my great pleasure to be the director of the School of Public Health and Social Policy. I really do want to welcome you all back to campus, and it's just so great to see you. I can't, it sort of feels like, a family wedding or, a reunion or something like that. Before we begin, I would like, of course, to acknowledge with respect the traditional territories of the Algonquin-speaking people on whose lands the University of Victoria sits, and the Songhees, Esquimalt, and Wasanich people whose relationship with this land continues to this day. As you can see, we have a full program. Just before we begin, I will let you know a little bit of housekeeping. The washrooms are straight out that door and right across the foyer, just beside the front entrance. We do have some snacks you may have seen, and coffee and tea. We've been asked not to bring beverages into the room, but I'll just close my eyes to that right now, because I don't want to create a stampede of people leaving. Cheers, Michael. Cheers, Nigel. So over the course of these next 2 days, we are going to be hearing from all of our colleagues about their practicum experience and what they've taken away in the learning journey that they've been on. But of course, we start our program with a keynote address from people of incredible stature, and this year we are not going to disappoint. This morning, it is my great pleasure to welcome Dr. Bonnie Henry. Bonnie is the Provincial Health Officer for British Columbia. She has an undergraduate degree, and Bonnie, I'm doing this from memory, so forgive me if I really screw it up. So she has an undergraduate degree from Mount Allison University, and then did an MD and MPH at the University of San Diego. Bonnie worked for the City of Toronto in public health and had an appointment at the Dalai Lama School of Public Health. I believe it was 2006, but I could be wrong, that you moved to BC. 2005, where she took up a position in the Center for Disease Control and also an appointment at UBC in the School of Public and Population Health. After spending some time as Deputy Provincial Health Officer, as of January, Bonnie became British Columbia's Provincial Health Officer. She has expertise in disease surveillance, in emergency preparedness, and in infection control. And she is going to speak to us today about a crisis that I would hope all of you are aware of. That is to say, the opioid crisis, not only in British Columbia, but across this country, although I think her remarks will be focused on the British Columbia experience. And with that, Bonnie, can I pass it over to you?
Now I'll just see if my mic is on. Yes? Great. Thank you. Okay.
All of you up in virtual land. So, excuse me.
No pressure. Thank you very much. Yeah. And I don't know about the stature part. I've never been known for my stature, but it is a real honor to be with you today, and it actually is it's a great honor for me to serve as the Provincial Health Officer as of February of this year, and I realized that I hadn't actually changed things, because when I first put up my presentation I still had deputy on there. So. But what I wanted to talk to you today was to give you a bit of a story about some of the stuff that happened when we were dealing with this overdose crisis. And I'm going to start sort of at the beginning and why we declared an emergency and what we were trying to do, and then talk a little bit about the story of how we came up with these overdose prevention sites, which I'm sure some of you are familiar with. And I've come to realize that there's still lots of myths about them out there. So I think it is an important story, and it reflects our role in public health on trying to support the community in a way that makes sense, despite all of the barriers that we sometimes come up against. And I as well would like to recognize, especially on such a beautiful day like today, and I'm very grateful for being able to participate with this in this forum with you here, the traditional keepers of this land being the Kungan peoples. So I'm going to talk a little bit about what we were seeing and what this overdose crisis really is in BC. And this was a revelation to people, I think. And I like to think that in the course of the 2 years that we've been dealing with this, and it was April of 2016 we declared an emergency, so 2 years that we have changed the discourse a little bit about some of these issues. And what we've recognized is these are not just those people, those addicts, the downtown east side, those people that are, they're on the street, it's, they're doing this to themselves. Why should we spend money and time looking after them? This is really a crisis that's affecting all of us. And it's affecting us in families, in communities around the province. And that was something that was different. This is a young man who died at a family wedding thinking he was taking cocaine. And it was laced with fentanyl. This is a young family, you may have heard of them on the North Shore. They had left their son with the grandparents and were preparing to move into a new house. He was starting a new job. He had been prescribed opioids some years earlier for a construction accident, and had become addicted to them. And we as clinicians had been prescribing opioids a long time, sometimes in very high doses, as we've come to recognize. And we were told, when I went to medical school, and actually was in Dalhousie in Halifax, we were told that people don't get addicted if they have pain and they take these long-acting opioids. Well, that's not right. And part of the problem we're dealing with is people who became addicted to opioids because they were on prescriptions at some point. And this young man turned to street drugs when he stopped getting his prescriptions because he had developed an addiction. That's not the whole problem that we're dealing with here in BC. It's a small part of the problem for some people, but he's a representative. And his wife, very successful personal trainer, the two of them went to their house and they took what they thought were OxyContin. And they got it from, their dealer that they trusted. And again, it was laced with fentanyl, and both of them were found dead in their home by their parents the next day when they were trying to find them. This is a very courageous woman who I've become quite friends with, Leslie McBain, and she lost her son to an overdose as well. So an unintentional overdose. And he was in recovery. They thought he wasn't using anymore, and then he, again, got a toxic dose laced with fentanyl and died. And Leslie has been trying to put a face on this crises around the country, and she started a group called Mom Stop the Harm, and they have some really great information, and they're very supportive, and it's been a forum for parents and families to actually talk about what happened and to talk and celebrate the lives of their loved ones they've lost in a way that reduces the shame and the stigma that sometimes goes with these. And so here's just a collage of some of the young faces of people in BC that we've lost in the last 2 years from overdose. And as you can tell, they're mostly young. What we're seeing are they're mostly young and mostly young men. This picture represents that. So this is what we were seeing, and I'm taking us back to early 2016. And down here in the 1990s, we've been actually following what the coroner calls illicit drug overdose deaths. So these are not people who die from their own prescription drugs. That happens every year, and there's about 70 people in BC every year who die from unintentionally taking too much of opioid that they're prescribed. And mostly they're older people who accidentally take a dose that's higher than expected and don't recover. But what we have seen over the years is that we've had some peaks, some spikes in deaths, and particularly in the 1990s, and 1997 being particular. And those were really concentrated. They were concentrated in the downtown east side, and it really was a representation of crack moving into the downtown east side. And there was an emergency, a public health emergency declared in the downtown east side in the city of Vancouver only. And so when we looked at this geographically in public health, we look at, who's being affected, where's the person, place, and time. And we found that it was really concentrated in that area. And that was really the impetus for some of the very innovative things we've done in BC around harm reduction and the 4 pillars approach, and being able to open the very first, and for a long time, the only supervised injection service in-site in the downtown east side. And that happened then, and that saved lives. And we saw a gradual decrease. It is kind of mind-boggling when you look back on it to think that 300 people dying a year was okay. That was normal. That was our overdose. Like, oh well, nobody pays too much attention to it. And then in about 2012, 2013, we started to see increases. And we have a group of, which I'll show a little schematic of. We started back in the late 90s, a group called the Drug Overdose Alert and Response Partnership, or DOPE, we call them, for some people will be familiar with it. And it's a partnership with the coroners, with health authorities, with people who use drugs, with people with lived experience, with police and public safety people, which are really key. And it was focused, run out at the BC Centre for Disease Control. It's when we started our harm reduction program, so needle exchanges and crack pipes and a few other things. And this group was starting to hear that we were seeing a lot of people dying more than normal, and that there was issues with the drug supply. We were particularly looking for this, and we did a lot of work prior to the Olympics, because we knew that drug dealers were planning for their Olympics as well. There's going to be a whole influx of people from around the world. And actually things were fairly quiet during the Olympics, but afterwards things started to skyrocket. And what we were noticing was it dramatically increased in 2015 and 2016. So we saw rising fatalities in 2015, early 2016. This is where we were when we were thinking about what are we going to do about this. We also were seeing that fentanyl in this drug supply was increasing. And when I talked to my colleagues around the country about this, they're like, oh yeah, it's those fentanyl patches that are getting into the street market. And we're like, no, that was like 5 years ago maybe. This is illicitly produced fentanyl or legally produced fentanyl without any regulatory oversight and no quality control, primarily in China, and these large manufacturing, and when I say a manufacturing plant, don't think of anything sterile, it's like big vats. It became really clear somewhere around 2013-14 that fentanyl is actually a substance that it's about 1,000 times more toxic than opioids, than morphine. And it's relatively easy to produce in large quantities. And because it is that much more potent in opioid units, you only need a small amount, and you can mix it in with whatever, and it's a whole lot easier to make and to import than to have to grow poppies and make heroin and purify the heroin and all of the stuff that goes with making heroin. So this illegally produced fentanyl has really taken over heroin, and we don't see any heroin on the streets anymore. It's all fentanyl, and that has created the crises that we're dealing with here. So what we were seeing was fentanyl went from about 20 to 30%. It was like almost nothing in 2010, 2011, 2012, and then it was about 20%, 30% of the overdose deaths. And then in 2016, it bumped up to about 60%. So people were thinking they were taking heroin, and they were getting fentanyl, and they were overdosing and dying. And so people who use drugs on a regular basis and who had substance use disorders and addictions, they were spinning that Russian roulette more often, more frequently, and more likely to die. And that's what we were seeing initially. And we had, in 2016, 922 drug overdoses, which was a doubling of what we had seen in 2015. And again, a tripling of what we had seen from 2014. And then in January of 2017 was our peak month where we had 116 people. So that's 4 people a day in this province who died. So this is a schematic of what we were looking at when we were saying, what are we going to do about this? This is 2010. And what this is the rate per 100,000 population by a health service delivery area, because we're health people, we tend to break things up into those areas. And the darker the color, the higher the rate. And so we were seeing things, that there were some pockets where things were worse. And then it started to change quite dramatically. So this is 2014, 2015, and then 2016. And this is just January to March of 2016. So as you can see, it wasn't just located in one area. It wasn't just the downtown east side. We were seeing this all over the place. We were seeing rates of people dying from illegal drug overdoses across the province. It was happening in small communities. It was happening in the north. It was happening in the urban centers. Clearly there was higher numbers in places like Vancouver and the downtown east side in particular. But it wasn't just Vancouver. It was Richmond. It was some of the more affluent areas. It was the South Vancouver Island. It was Nanaimo. It was Interior. It was Kamloops and Kelowna. So we saw regional variations, but we also saw there were many different groups at risk. So people who were using opioids on a regular basis obviously had a higher chance of encountering some of the illegal drugs that we were talking about that had poisoned the street market. But we also saw that there was a high rate of death in people who had just been discharged from corrections and discharged from abstinence-based opioid addiction treatment. So it made us start to look at, what are we doing around this for people who are treatment. So much of our treatment system in BC and in Canada, and actually much of North America, is really based on alcohol. And it's an abstinence-based model, and I'll talk a little bit more about that later. There was some very high-profile deaths in young people in particular who were experimenting and thinking they were getting oxys or Xanax, which seems to be a common one to use in some of the youth groups. And they were getting street drugs that were contaminated with fentanyl and then other analogs of fentanyl. And there were stimulant users. So people who use cocaine don't expect to get a depressant in their drug. And we know that the stimulants were now being cut with, but because fentanyl was so cheap and so easy to import, and you could give people a high with a very small amount, drug dealers all over the place were mixing it in with stuff. So the cocaine market was infiltrated. Not all of it, and right now in BC, about 8% of the cocaine samples that we that have tested are contaminated with fentanyl or carfentanil or other opioids. But people who use stimulants don't have any tolerance to opioids, and they were dying as well. And then we have a group of people who may have been on opioids prescribed and continue to be prescribed in very high doses for chronic pain in many cases. And it really stimulated our discussions and thinking around how poorly we support people with chronic pain, because we now know that the evidence tells us that opioids don't actually do much, and they're not very helpful for people with chronic pain. But you can get them from prescription, and it's paid for, and you can't get your physio or your mindfulness-based stress reduction or the other modalities that actually do help people with chronic pain covered. So all of that is to say that it's a complex problem. And I've touched on some of the things, but what we were seeing was the demand was going up, the illicit drug supply in the streets was contaminated and poisoned. We were seeing some diversion, but that wasn't the main part of the problem. And then we were seeing people who were overdosing, who weren't able to get into treatment. Getting into methadone treatment was a challenge, and people were dying. So I did mention we had this drug overdose alert partnership, and this is sort of the main people who are in this partnership, and they helped us understand what was going on. So we did law enforcement, public safety, emergency health services, and we were hearing from paramedics that they were being called to these overdoses all the time, and what was going on. The Drug and Poison Information Center, health emergency departments, people with lived experience, and allies and family members, and researchers. And they were all telling us, this is different. Something's going on. It's the drug supply has been poisoned. So on the 14th of April, 2016, Dr. Perry Kendall, myself, and the Minister of Health at the time, Minister Terry Lake, declared the first ever public health emergency in BC. And we have the Public Health Act in BC, and it allows us to declare an emergency for unusual situations. And the reason that we did that And it was not an easy decision. We had a lot of consultation with our medical health officers around the province, the chief MHOs in particular, and the thing was, what can we do if we declare an emergency? And then we had a lot of discussions with the political side. And you know, everything we do, if you don't have political support, sometimes you can't get to where you need to go. But getting some political support is sometimes a challenge. And our minister really understood this issue. We spent a lot of time with him. But he had to convince his cabinet colleagues that this was important enough, that we needed to, they needed to support us in declaring an emergency, and they needed to put resources and money into trying to address this. No easy feat. And I think he was very brave to take this on. And I still think he was very brave to take this on. So we would have declared an emergency with or without the political support, but it sure made a difference to have that support. And they did support it, and we wanted to do it, one, to raise public awareness, to be able to talk about these people who were dying as people, because there was so much misinformation out there and so much bias and so much stigma and shame around people who use drugs. It also helped us to improve our information sharing. So we were able to require emergency departments to share information with us around people who were surviving their overdoses. Because at that time, most of the information we had was about people who were dying. And we wanted to know, you know, there was probably a factor of 10, as we've come to find out, more people who were overdosing and surviving. And what was different between those? And what was different in their trajectory, in their life history, in the period of time before they overdosed, where they might have had interactions with the health system, where we could have intervened, where we could have done something. We also wanted to strengthen some of the existing interventions, and I'll talk a little bit about those, and then put some collective thinking into what else can we do to try and save lives, why we understand what's going on with this problem. So there was a 7-point overdose response plan that we started, and I won't talk most, there's a couple of the points were around federal enforcement and interdiction strategy, seeing if we can stop the supply, but really it's the demand side that we were looking at. And there's some there were some initiatives around police and supporting of harm reduction efforts. And that, if you think back to our previous governments, both federally and provincially, about 80% of BC is policed by the RCMP, and the RCMP are very federally driven, and you were not allowed to use the term harm reduction in Ottawa with the previous government. So it was an anathema. So all of the RCMP had nothing to do with harm reduction. They didn't want to do anything with supervised consumption. They weren't prepared to do to use take-home naloxone. So we had a lot of. They weren't prepared to support communities in developing their own supervised consumption services or harm reduction services. In some communities, they even passed bylaws where you couldn't hand out clean needles. There was no needle exchange. So this was a phase shift in thinking for many of our public safety colleagues. Thankfully, we have some very progressive thinkers, particularly the Vancouver Police Department, here at Vic PD. There was a change here, and we did some work with them. And our Clayton Pecknold, who's the police superintendent at the provincial level, is a very brave man and took this on and was extremely helpful in helping us talk to police and public safety about how important this is, and about the thing that struck me is I was talking with one of the senior leaders from Vancouver Police Department, and he was talking about working in the downtown east side when Inside opened, and how they were so supportive of that, because as he said it, you know, my job is to serve and protect, and that means everybody in my community, including people who use drugs. And it's better for me to take them to a place where they'd be safe than for me and my colleagues to find them dead in an alley the next day. So that thinking was really different from many people in law enforcement around the province, but I think we've changed that now, and I think that's the success. So that's all I'll say about that. So particularly immediate response to the overdoses, that's what our thinking was, okay, we need to keep people alive. what can we do that will help? And one of the big things was we had started what we call take-home naloxone program. So naloxone is a medication that can reverse the effects of opioids. So it basically binds to those receptors and blocks off the opioids and brings people back, essentially. And we had worked with a group of young people who developed some messages around using naloxone, and their theme was naloxone wakes you up. And I thought, that's exactly what it does. So we expanded the supervised consumption services, and but at the time, so these Insight it has an exemption under the Controlled Drugs and Substances Act, which is federal legislation. And the process that the previous federal government had put in place to obtain objections, so they went to court to try and shut Insight down and to get rid of anything, any exemptions under the Controlled Drugs and Substances Act. And so when they lost the court case, what they did was put in about 26 different steps you had to go through to open a new supervised consumption site. And they were labyrinthine, and it took forever, and they had to have inspections, and you had to do community consultations, and you had to have letters from your police, and it was designed to prevent any more from opening. So when we declared an emergency, we said each health authority needs to look at where they might need this type of service, and we will collectively work with Health Canada to try and move this ahead. And so they streamlined the process so that there was only 5 steps to go through, but it was still taking a long time. But one of the things we could do really quickly was increase access to naloxone. And so this was a program that I had fought a lot for when I was one of the leaders at BC-CDC. And again, it was not politically really popular. But when we declared an emergency, we got some money and funding to actually do this in a much more concerted way. And so now there's over 500, almost 600 places in BC that you can get them, including over 1,000 pharmacies, community pharmacies, emergency departments, all over the place. We've distributed over 50,000 doses that we know have been used, and that's when people report back to us that they've used them. And we've replaced them. And we've been doing training all around the province about how to use naloxone and not to use alone, so that people have somebody there who can bring you back if you are going to be doing this. And I will point you towards theheart.com, because there's lots of really great information on that website about naloxone and about overdose as well. We beefed up the comprehensive overdose program and a lot of messaging and public discussions about prevention, recognition, response, what to do. One of the things, interestingly, when we started all this, naloxone was actually a prescription medication, which it was a Schedule A, which means it had restrictions on it, which is kind of bizarre. So we're successful in lobbying Health Canada to take the prescription status off, and so now you can get it anywhere. You used to have to get a prescription from a physician to get it, and we got around that with our take-home program, with having a blanket prescription from us, from the physicians at the BC-CDC, to allow them to dispense it through these training programs. The other thing but now you don't need that. You can go to any pharmacy. Anybody who's at risk of an overdose or witnessing an overdose can obtain a naloxone kit. You have them here at UVic. We've been working with student services. Thankfully, this is not a high-risk place on campus anyway. The other thing we were successful in supporting was amendments to the Good Samaritan Act. So this protects you from one of the things that we found when people were using naloxone kits is they were afraid about half of the time they called 911. And that, to us, is really, really important, particularly as fentanyl and carfentanil and other analogs came into the street circulation. A single dose of naloxone may not bring someone back. They may recover, and then they may actually, the long-term effects of the opioids may come back, and they may overdose again, or they may relapse into respiratory arrest again. So calling 911 is really important. And people were afraid to do that because they were afraid they'd be arrested for having illegal drugs. So the Good Samaritan Act now says that you can't be arrested for simple possession for calling 911 for a response to this. And what we also changed, we worked with our public safety partners, is they're not the first responders. So it used to be that police would be called for every 911 call, and they would show up at the scene first often, and that was very intimidating for people, not surprisingly. So now it's the paramedics that go first, except in some of the smaller communities where you may not have a large paramedic, and the police do respond, and now they actually use naloxone. And the first time that the RCMP in Surrey, there was somebody who actually overdosed in the RCMP headquarters in Surrey parking lot, and one of the members of the police force went out and used naloxone and saved that person's life. And they all became converts. It's like, okay, this is good. This is part of us being part of our community. So other things that we did were trying to make it easier for people to get into treatment, particularly people who overdose and survive in emergency departments. We now have rapid access to treatment at that key period of time where they might be amenable to it. When you've overdosed and you wake up in an emergency department and you're not feeling very well, this is a period of time when people can be into treatment. But we also know that opioid addiction is a chronic relapsing condition. People almost always relapse, even when they're on methadone or Suboxone. One of the things that we did with this overdose is with this declaring of the emergency is the government put some funding towards the BC Centre on Substance Use. And Dr. Evan Wood and his colleagues there have been doing amazing work at helping us understand opioid addiction and substance use disorder and how to best treat it. And now some guidelines have come out. They've been they've been adopted as the national guidelines. And they're about how do you particularly use Suboxone to help people. So Suboxone is a mixture of naloxone and a compound very similar, buprenorphine. It's similar to methadone. So, but it doesn't give you the high that you get with when you're taking small doses of things like fentanyl. It's a much more even. But it helps reduce the side effects of withdrawal, which can be really, really horrible. So people describe opioid withdrawal as, they get body aches and headaches and nausea and stomach cramps and diarrhea. It's not a pleasant experience, and your brain doesn't want you to go through that and to suffer. So this very strong need to get more of the compound of the opioid to try and make you feel like you're okay. So people don't get, the first time they take it, people tell me that they feel like euphoric and that I'm normal or that I'm okay. And it's a way for many people of dealing with either physical pain, emotional pain, psychic pain from adverse childhood experiences, things that happen in your life that you're trying to deal with. But once the drug, once your receptors in your brain are changed by this drug, they need more and more just to be on an even keel. You don't actually feel that euphoria anymore. So it's a really, really challenging addiction, very different from other compounds. We did a lot of work on public and professional awareness, and people like Leslie McBain have done a lot to help put a human face on people who use drugs and people who are involved in this. And I won't talk about all of these, but we started a whole bunch of things to try and understand this better and understand about what was happening and where we could intervene in the system. And I know some people in this room have been involved in some of these research and applied. So here we were. We had declared this overdose emergency in April. And then in October of 2016, the numbers were still going up. We had 622 deaths between January and October. The coroner's service had predicted, they were telling us that there's at least 100 overdose deaths that they were investigating in that month of November. And more capacity was becoming an issue because it took time to get the toxicology testing, it took time to investigate these. We actually have purchased now 2 portable morgues in the downtown, in the lower mainland, because we did not have space left. And that's the impact that it's had on our community. The emergency departments in Vancouver in particular were being stretched. St. Paul's was an overdose response center, essentially. And people who had other medical conditions, which were all happening as well, were having a challenge finding emergency departments. And it was getting to people. The first responders, the people in the community, people who use drugs, and the networks that we were connecting with, they were losing people rapidly. The health sector was stretched. The BC Ambulance received over 800 calls. So this is November of 2016, in 1 week, all related to overdoses. And we started identifying carfentanil, which is about 10 times more potent or toxic than fentanyl. And it's an elephant tranquilizer, you might have heard of it, but again, it was illicitly manufactured, so there was no quality control. So some bits of powder or drug would have a small amount of it in, and some would have a large amount, and people were dying in just rapidly increasing numbers. The critical care capacity at St. Paul's. So people who were surviving some of these overdoses were having long-term health issues and needing to be in ICU or in critical care, many of them with chronic brain injuries. As December approached, we were kind of desperate. What was happening here? We were starting to see carfentanil, the deaths were increasing. We were having reports from community workers, and I don't know if there's anybody in this room who's spent some time, but in supportive housing, in the shelter system, the people who worked in those environments were finding people dead in the bathrooms, or checking on somebody and finding them dead in their bed, or coming into work in the morning and there was a body in the back alley of somebody who they knew who lived there. And all of this was because it's still an illegal drug, and people were using alone because they were afraid. And they were afraid of being arrested. They couldn't do it in a public space. They couldn't do it where somebody could watch them. And we had a really cold winter. So that December, the cold weather was happening, was making conditions worse. It actually makes you physiologically worse too. The demand on EMS in the emergency departments was increasing. The situation was really kind of dire. And we were seeing response on the ground with some very brave people. Sarah Blythe was one of them. They started these pop-up sites, mostly tents with peers, and peers who knew how to use naloxone, because that was the one thing that was keeping people alive. And a lot of people, particularly in downtown East Side, in Surrey, in the urban areas, they were carrying naloxone kits and saving their colleagues and their friends and their family. So these tents started popping up where people could use, and there wasn't medical people who were there. It was your peers. It was some of the people who did social work in the downtown East Side, in particular, where these started, and they would talk to each other about what they were using, and there was this little network of, okay, those purple ones, be careful because 3 people this morning overdosed on those, and they were saving each other. They were using naloxone, they were doing rescue breathing, calling EMS sometimes, and we set up the mobile medical unit that we have in the downtown East Side so that people could go there instead of the emergency department. And we had this rapid induction into services and being able to support people. And we provided some guidance in some of the supportive housing where they could have an area where people could use, and there would be somebody there who knew how to use naloxone and would call 911 if something happened, rather than forcing them to go out in the back alley or into a place where they used without anybody there to support them. So the Overdose Prevention Society, this is one of the first tents that opened in the downtown East Side. But we were also getting concerns about staff worrying that, if they did this, would they be in contravention of the Controlled Drugs and Substances Act? And the answer was probably yes. But it was still taking, as I mentioned, like way too long for Health Canada to approve any of these exemptions. And they just did not get that this was a crisis. Us talking to Ottawa was just like, it was so frustrating. And we went there a number of times, and the province of Ontario kept saying, oh, it's a diversion of prescription drugs, it's not a problem here, nothing happening here. And Ottawa, being so closely connected to the province of Ontario, was not really getting that this was an urgent problem and that we were seeing things that they were not seeing there, or at least they weren't looking for in the right way, in my mind. They are now. And it was taking a tremendous toll on our frontline responders and our social services agencies. So we felt really strongly there needed to be a provincial solution. Along with that, the minister, Terry Lake, was at home in Kamloops, and it was a cold night, and he was in he wasn't at home, sorry, he was away from home. He was in his hotel thinking, my God, you know, these people are out there on the street in this cold. It was snowing. It was just miserable. We need to do something. And we had been working, Dr. Kendall and myself, around how can we use what, for the policy wonks out there, what we have is legislation to try and make this work in a way that will support people during this crisis. So what we actually ended up doing, and again, another kudos to Minister Lake, he issued a ministerial order under the Emergency Health Services Act, the Health Authorities Act, and the emergency we declared under the Public Health Act, which actually allowed him to declare these pop-up, we named them overdose prevention sites, or overdose death prevention sites is what we called them first, but overdose prevention services as medically necessary health services under the emergency that we declared. And under the Emergency Health Services Act, there was a little clause that allowed you to allow lay people to do medically necessary services, health services in an emergency. So it was like, okay, we can put all these three things together and we can do a ministerial order that makes these legal. And regardless of the Controlled Drugs and Substances Act, because it was a health service that we were providing, and that was supervising people using naloxone, making sure that they could survive these. And within days, we had a number of these set up, and I'll talk about that in a sec. So just one of the things I wanted to mention was that cold weather meant that many people were using indoors, and then, of course, they were away from people who could observe them. So these overdose prevention sites were a low threshold site as an emergency measure where staff can monitor and intervene to prevent irreversible brain damage and death. And within a month, we had over 22 of them around the province, serving various populations. So it became really clear to us that people who did not use Insight would use these. So there was one that was mostly women that went there. There was other sites that were set up for mostly Indigenous people who felt more comfortable with what the people who were there and how they were being set up. They became a place where people were treated with respect and compassion and understanding, and where they could link to health services. So we could get them clean socks. We could look at the wound on their leg. We could help them with their cough that they were trying to deal with. And we could link them with, oh, well, you know, here's what I did when this happened to me, and talk to this person about maybe getting into housing, maybe looking at treatment, and here's what treatment means to me. So these were became places where we could connect with people who were using drugs in a way that we had not had the ability before. And they took many different forms. This was the one that they set up in the interior, because they don't have a sort of a collection in one area. This is a mobile supervised consumption site, and it's since been certified by Health Canada, so it's officially under the Controlled Drugs and Substances Act, and we have a bit more services that are available through it now. So there's these in Kamloops and in Kelowna, and there's a number of places across the province. And this is the stats from about a month ago. We've had over 500,000 people who visited these places. And we've had a couple thousand overdoses happen in those spots. We've had nobody who has died at an overdose prevention site or at Insight or at any of the supervised consumption services. And to me, this is a success. We are keeping people alive until they're at that point in their life where they're able to enter into the journey of recovery. So what have we learned from these? There's a lot of concern when we started these, and now they're opening up across the country. And you know, I was talking to my colleague from Ontario just last week, and he was like, "Oh, you know, what happens, what if the people who work there, are, they're going to be liable, or if something bad happens, and you know what? The sky did not fall. These places were places where people felt safe to come, and it met an important need, and it has saved lives. It's a gateway for other services as well. We found that it's a place that we can reach people. And we've started doing things like drug checking. So we have some limited capacity. The technology is not where it needs to be yet, but we're doing some research around drug checking. So how does it change people's behavior if I know what's in my drug or not? And particularly we know for people who are using things like methamphetamines or cocaine, it makes a huge difference because they will not use the drug if it has carfentanil or something contaminating it. So we haven't solved the problem, but that was one of the stories of how we got where we are. We've got a lot of information. We've developed a cohort where we can compare people who have died from overdoses, people who have survived, and the rest of the population, a sample of the rest of the population, and look at what are their trajectories in life that are different. One of the papers that was just released last week shows that it's a modeling study that looked at the impact of the take-home naloxone program just before we started the overdose prevention sites, because it really ramped off after that. But even before that, we probably, the blue is the deaths prevented by the take-home naloxone. So it just defies thinking of how much worse this could have been had we not done some of the things that we did. But it is a complex problem. This is this week's dashboard, so we continue to monitor things on an ongoing basis. And as you can see, there are some areas of the province that are still really dark red. We have the last month statistics that we have from the coroner's office. There were 100 people who died in February. That's down a little bit, but it's still a phase shift above what we had seen before, and it's still over 3 people a day in this province, which is way too much. And we've started to understand a little more about who is being affected. Much of what I talked about has supported people who are often street involved or who are chronic users of drugs. What we're now seeing is that people who are dying, 80% of them are mostly young men who are using at home or in a residence, a place of residence. And we are calling this the hidden epidemic, because people are using, their families and friends may not know. They often will tell the coroner that, well, I know he was using before and he started on this, but he was in treatment and he was doing okay, and I didn't know that he had relapsed. And he was afraid to tell us. And these are the things that we're hearing, that they often, it's underlying experiences around social use and fun and pleasure, but isolation and stress and anxiety, or physical and emotional pain, and you get into this cycle. And we know that this, as I mentioned, is a chronic relapsing disease. So we've done some work to try and understand that population, and you won't be able to read all this, but it's around, what do we need to do to address some of these issues? And things like, what are the gaps that we have in our system? We don't have a mental health and substance use system, treatment system in this province. We haven't for a long time. We now have a new Minister of Mental Health and Addictions, Minister Judy Darcy, whose main focus is on the keeping people alive, but also building this system. And she's got a Herculean task ahead of her, but we're working really hard on this. How do we address those pieces along the continuum, so that obviously we want to deal with prevention in our world, so preventing early childhood experiences, adverse experiences, identifying people early, understanding how prescription opioids play into this, understanding how we can get people into treatment and support them in recovery. So there's a whole lot of things that we still need to work on, and I think some of the really important things we've learned are people use alone because of stigma and shame. They don't want their families to know. They're afraid. People don't talk about it. I'm not one of those drug addicts, those disposable people from the downtown east side. So we started to really talk about, we've started a campaign that's addressed really at all of us, so people understand that drug use is not People who use drugs are not other. They're us. They're our family. They're our friends. They're our cousins. They're in our community. They're people we know. So this is one of the campaign posters that we've come out with. And we've started a website that helps with supports around how to have that conversation with young people, how to have that conversation with your family about drug use, and how to do it in a way that is safe for you and for them, and where to get support. And it's called stopoverdosebc.ca, and I may have seen some of these posters. So I'm going to stop there, and I'll leave you with this, stopoverdosebc.ca, and I'm hoping we can have some conversation. Thank you.
So I guess I'm going to play Phil Donahue. We would like, if you have questions, to please use the microphone so that people who are watching online can also hear. So, Bonnie, again, thank you for just a compelling story, filled with so many different lessons for all of us. Yes.
Oh no. I'm sorry, I went on a little for longer than
Hi, Bonnie. Lillian Bain. I'm going to try not to. That was amazing. And I teach in this program, as you know, and what I teach is the role of government and policy. And there are so many points in your talk that really struck me. Just the whole idea of the complexity of the kinds of issues we deal with in public health. The interplay of jurisdiction, which I think is really critical. You talked about, the RCMP and some jurisdictions having their own policing at the municipal level, the role of the province and so forth, the role of law and how those have to be changed. And also the competing, which you alluded to in talking about this being across society, the competing public opinions on this issue about how should we be doing this? Is it a harm reduction or is it another strategy that we adopt? And those are very strongly held views. And what I really want to do here more than anything else is to say thank you, because it took such courage by you and Dr. Kendall to do what you did. I mean, you challenged so many different laws and so many different rules, and that is incredibly hard to do in government. And I just want to say thank you. Wow.
Thank you. It is true, and it's shocking to me. And it was a learning experience for all of us to be able to use the right language and to. My whole thing is it's about people, and that's what we do in public health. Is we look after people on an individual basis, on a community basis, and it's people who use drugs and making sure that we put the people first in these issues. And I testified at the Senate Committee on Health in sort of September-ish of 2016. And there were some of the members of Parliament who were on that committee who still said things like, well, it's those addicts. Why are we spending money on those addicts? And nothing you do is going to make a difference, and they choose to do this. Why do they choose to do this? And, you have to respect them. They're our elected leaders, not senators, but MPs. And to try and help them see that, no, these are your kids. These are your kids' friends. These are your sons and daughters. It's a challenge. But I think that I believe we have changed the public discourse in a way that I could not have imagined possible necessarily way back then.
Trevor?
Hi, Bonnie. It's Trevor Hancock. Can you go back about 3 slides to the slide called Hidden Epidemic? That's it. So one of the things that I've been concerned about is the extent to which public health is very engaged in crisis response and all of that. But the real issue is sort of on the left-hand side of this slide here, which is what's going on that's getting people into using both prescription and non-prescription opioids in the first place. And part of that we know now is Big Pharma and the way it marketed this product very irresponsibly in the way that it was prescribed. But I'm wondering about what's even upstream of that, which is why is there so much both physical and psychological pain? Where's that coming from that is driving people to seek medications, driving them to seek painkillers. And what do we do about that? And that's the big upstream issues that I worry that we are missing or not paying enough attention to, because we're so. I used to have a friend who said that we're so busy dealing with the important that we're not examining the critical. And there are these critical upstream issues, and I see they're on there, so that's very comforting. But I'd be very interested in hearing what you think about how we approach those kind of issues, how we make sure we don't have that kind of, frankly, regulatory failure again around the marketing of opioids, and how we deal with the pain that's driving people to this in the first place. Where's that coming from, and what do we do about it?
I think that, that's a really important thing. And one of the things I didn't talk about was the disproportionate effect of this crisis on Indigenous peoples in BC. And, they have Indigenous men have a 5 times increased risk of dying from overdose. And where it's mostly men overall, in the Indigenous community, First Nations population, it's almost equally men and women who are affected by this. And we know that a lot of that relates back to intergenerational trauma, having challenges in dealing with substance use, addictions, the fragmentation of their society and culture. So we know that has a huge problem, and I think a huge impact on this. And some of the things we are doing around working with Indigenous communities around the model for recovery and treatment, which is very much based on an abstinence model for a variety of historic reasons, is important. But also looking at culture as medicine, and how do we help work with First Nations communities to reestablish their culture to support people, both Indigenous people, the members of the community who are living away from home, a lot of them in the urban areas in BC. So I think that's a really important piece. And a lot of it, for others, there's that group of people who are experimenting, but there's the psychic, emotional pain and anxiety that young people go through that drive them to this, and a certain proportion of people will become addicted. And how do we address that? We're starting to understand some of the adverse childhood events and how that impacts you moving forward in life, and how do we prevent those? I think those are the big questions and challenges that we're faced with. But you're absolutely right. It's the upstream stuff that is really important.
Audrey?
Hi. So last week there was an overdose death in Oak Bay. A 16-year-old high school student, he'd been prescribed opioids as part of recovery from surgery, and it became a habit that he was getting street drugs for. And I gather pretty much everybody in his school community knew that was happening, but was helpless to stop it. So as a community, Oak Bay would really like to address that and to move forward in a positive way, so that I think there's it's a very affluent community, and this thing is kind of a shock, but it's clearly always been kind of simmering as a potential risk. So do you have any advice for how a community can address this, like how we could prevent this from happening to other students?
Yeah, it is a challenge, and I'm well aware of that case, and I know the minister who I talked with was meeting with them yesterday at the family. So I think part of the way to address it is to talk, and to talk to young people about the drug use, about what it means, about what the risks are. And, I hear from some of the discussions I've had with young people, and from my nieces and nephews in particular, that some types of drug use are actually quite common, shockingly common to me, from my generation, I guess. And there's not an understanding of risks, I don't think. So I think number one is having that conversation in a safe way so that people can talk about it. And in the short term, I think one of the important things is making sure they know the risks and are able to at least access Naloxone and support each other at parties. But helping young people understand how to make a choice around some of these issues, and it's not something that can happen quickly, but that they also can talk to their friends when they think their friends are getting out of control. And to not be afraid to do that. And I know it's really hard, and to find those words to say, like, what do I say? How do I say it? How do I say it in a way that they don't just go, yeah, what, and turn away? And we have some really useful strategies on this website about how to have a conversation. You know, what happens if I get angry? What words do I use? How to bring it up in a way that, you know, bring it up in the car, because, you know, they don't have to look at you. Strategies where you can actually have a conversation, and it's not just one. It's like, it's okay to talk about this. We'll talk about it some more. I think where the challenges are is if we say, oh my God, look what can happen, don't do it. And I think we're going to have more challenges when we have legalization of cannabis coming, because it's not going to be legal for young people. I think it'll be safer because it'll at least be regulated, and they won't have to deal with drug dealers who are often deal with a whole bunch of things. So that to me is a good thing. But we have to have those conversations. And this is one of the things we're trying to say, that, you know, these are families and communities have to have these conversations. This is not just about those other people.
Well, Bonnie, I want to thank you for stimulating the conversation. Unfortunately, we're out of time. I know that there are others who are wanting to ask questions, and perhaps if you have a few minutes, maybe you could just ask your question of Bonnie. I do apologize for not being able to get to everybody. But again, on behalf of everyone, Bonnie, I think we really want to thank you for starting us off in a very positive, thoughtful, and important way. Thank you
Thank you very much.